Hello everyone. This video is on the clinical features as well as the diagnosis of liver cirrhosis, and in the previous video we've already covered the introduction to liver cirrhosis, the histological presentation of liver cirrhosis, all the steps involved in the pathophysiology, and all the etiological factors contributing to liver cirrhosis. So now let's move on to our next point, which are the signs and the symptoms, so the clinical features of liver cirrhosis. Now, cirrhosis of the liver is a slow and gradual process in its development, as I've told you. It is usually well advanced before its symptoms are noticeable enough to cause alarm, and the early symptoms may be weakness and weight loss. Now, the clinical presentation, it's highly variable, and most of the times the patients even may be asymptomatic, and the diagnosis may be made incidentally at ultrasound or surgery. Some manifestations of cirrhosis are non-specific even and may also occur in several unrelated conditions. So the basic thing that you have to remember as we go over the clinical features are three things that happen in liver cirrhosis. The primary being liver dysfunction, the second portal hypertension because of the obstruction of the venous flow to the liver, and the third are non-specific causes thereof. So first and foremost, we have some non-specific symptoms such as weakness, fatigue, muscle cramps, weight loss, anorexia, nausea, vomiting, and upper abdominal discomfort. The next, we have hepatomegaly. So in some cases, the liver size can be enlarged, it can be normal, or it can also be shrunken in some cases. Then we observe jaundice. So jaundice is basically due to an increase in the bilirubin levels in the blood circulation. So you remember I told you liver dysfunction. So one of the results of that is increased bilirubin levels. Now this leads to a yellowish discoloration of the mucous membranes, the skin, and more evidently the sclera of the eye. And this is one of the symptoms that we notice. Apart from that, we see some circulatory changes and endocrine changes because of an alteration in sex hormone levels. So let me show you first this. So this is a picture of spider telangiectasia or spider nevi. Now these are basically vascular lesions, as you can see here, and they occur due to an increase in estradiol. What you can notice in this diagram is that there is a central arteriole and it is surrounded by these radiating smaller vessels, right? So this gives it the appearance of a spider, and this is why it is called spider telangiectasia. Apart from that, we also notice palmar erythema or the reddening of the palms, and this is the result of increased estrogen. Coming to the endocrine changes, these are very early on seen, right? So the endocrine changes, they include gynecomastia in men. So this is because of an increase in estradiol, and apart from that, we notice decrease in male sex hormones which cause loss of libido, hair loss, testicular atrophy, and in some cases infertility or impotence. In women, that would translate to breast atrophy, irregular menses, and amenorrhea, right? So we have seen some cases have hepatomegaly or shrunken liver. There's presence of circulatory changes like spider telangiectasia and palmar erythema. We see jaundice, and we also see some endocrine changes such as gynecomastia and other such changes. Apart from that, we see ascites, which is the accumulation of fluid in the peritoneal cavity, right? So this gives an increase in the abdominal girth, as you can see. And in case this fluid accumulation is more than 1500 ml, it gives rise to flank dullness as well. So now we'll move forward to the things that are caused by portal hypertension. So the first up we have here is splenomegaly. This is an increase in the size of the spleen, right? And this is because of congestion in the red pulp. So this is a result of portal hypertension. Apart from that, we see collateral vessels. What does this mean? So the next thing that we see are esophageal varices, gastric and colorectal varices. Now what this means is, because of the increased portal hypertension, instead of the blood going where it was supposed to, there will be formation of collateral portal blood flow, right? So instead of where it was supposed to go, an extra amount of blood will be going to the esophageal vessels and the vessels in the stomach and the colorectal vessels. So this would lead to the vessels becoming enlarged in these areas, and these are more likely to rupture, right? So let me show you a picture of that. These are esophageal varices, right? So you can see that the veins, they're dilated and these are more prone to bleeding. The next one we have is Caput Medusa. So Medusa, basically, Medusa was a Greek goddess, okay, and she had venomous snakes in the presence of hair, right? So when we look at the abdominal walls, we see something similar to the Medusa, right? So you can't appreciate it that much in this picture, but what basically happens is the same as the previous step. Instead of the blood going where it was supposed to, the blood from the portal venous system, it is shunted to the periumbilical veins and ultimately to the abdominal wall veins, right? So the blood accumulates in the abdominal wall veins, manifesting as the head of the Medusa. The next thing we have is the fluid, which is a venous hump that is heard in the epigastric region on examination with a stethoscope. Finally, I've written here hepatic encephalopathy. Now, because of again liver dysfunction, there is a buildup of ammonia in the circulation, and this can damage the brain. Now, one of the clinical findings of hepatic encephalopathy is also asterixis. So we'll discuss this in a bit. So far we've seen ascites, which was accumulation of fluid in the peritoneum. Apart from that, we saw certain causes that were because of portal hypertension. So now let's discuss some unspecific or unestablished findings that we see in cirrhosis. The first one we have are name changes. So starting with murex lines, here we see horizontal bands, right? So you see horizontal bands of separated by normal color, and this is because of hypoalbuminemia. Now we know that albumin, it is synthesized in the liver. So a dysfunction of the liver would stop the production of albumin, resulting in hypoalbuminemia. Apart from that, we have hypertrophic osteoarthropathy. Apart from that, we missed out Terry snails. So in Terry snails, what we see is the proximal two-third, it appears pale, whitish, and this area, the borders, they appear to be reddened. This is again because of hypoalbuminemia. Apart from that, we have clubbing. So we know that the angle between the nail plate and the proximal nail fold increases in clubbing, right? So this is not like specific for cirrhosis, but it is one of the things that we can also observe. Apart from that, we have hypertrophic osteoarthropathy. There is chronic periostitis of the long bones, and it might also be very painful. Then we have Dupuytren's contracture, where you can see it in this picture. There is the thickening and the shortening of the tissue on the palm of the hands, right? So there's thickening and shortening of the tissue on the palm of the hands, which leads to flexion deformities. And these are usually the result of disorderly collagen production, right? So here you can see flexion deformities. Apart from that, we have some known outcomes, which are fetus hepaticus and asterixis. Now, fetal hepaticus is basically a musty breath odor, and this is the result of increased dimethyl sulfide in the breath. Then we have asterixis, and as I told you when we were discussing about hepatic encephalopathy, this is one of the things that we observe. So here, when the hand is outstretched, there's like a bilateral asynchronous flapping. Okay, so it's like sort of flapping, and that is a sign of hepatic encephalopathy. So now coming to our final few clinical features. Here we have, first of all, we've already discussed hepatic encephalopathy because of the increase in the levels of ammonia and related substances in the blood, which are not cleared because of liver dysfunction. Now, apart from that, we have these. Now, you must remember that liver is where there is the production of all the coagulation factors, a lot of coagulation factors. So, liver dysfunction would disrupt the production of those and lead to hemorrhagic tendencies, bruises, purpura, and epistaxis. Apart from that, we see sensitivity to medication, and this is because of the decreased metabolism of the drugs. Then one of the severe things can be hepatorenal syndrome, where there is acute kidney injury, and we can also notice muscle wasting and weakness in some people. So now let's quickly go over the diagnosis. So as I had already shown you the histological picture of the cirrhotic liver, we had seen the fibrous scar tissue, which was separating the proliferating hepatocytes into nodules. So therefore, our gold standard for the diagnosis of cirrhosis is definitely a liver biopsy. However, in patients with chronic liver disease, the presence of the various clinical features that we've already discussed are suggestive of cirrhosis. In the physical exam, it's always ideal to look out for vascular spiders, palmar erythema, palpable left lobe, small liver span, splenomegaly, signs of jaundice, ascites, and ectasis. So this could also aid to our diagnosis of liver cirrhosis. Now, in our lab findings, the first thing that we have here is thrombocytopenia. So this is because of two reasons, right? The fall in platelet level below 1,60,000 per mm³ is either due to one, splenic congestion that we have already seen, and two, due to the decreased production of thrombopoietin in the liver, right? So that would lead to a decreased platelet count. Apart from that, we can do some liver function tests like prolonged prothrombin time because of the lack of clotting factors, decreased level of albumin because of the synthetic function of the liver being lost, and an increased level of bilirubin because of inadequate metabolism. Then we have liver damage tests, which would be aminotransferases and alkaline phosphatase. We would see the AST level to be greater than ALT. All of these are elevated. Apart from that, we can also have certain tests like globulin, which are increased, hyponatremia, leukopenia, and coagulation defects, as we've already seen that clotting factors are not produced. Apart from that, others are serology for hepatitis virus, autoantibodies for the same, and in patients with hemochromatosis and Wilson's disease, it's ideal to go for the ferritin and transferritin saturation to check for the iron levels, and apart from that, copper level and the alpha antitrypsin. Right, so these were our lab findings. Finally, winding up with the imaging. Now moving on to imaging studies, the first one we have is liver ultrasound. So this is non-invasive, but it is routinely used in the evaluation of cirrhosis. It can easily help us understand a decrease or increase in the size of the liver, the nodularity, echogenicity, the portal vein enlargements, venous collaterals, splenomegaly, Budd-Chiari syndrome, and maybe a prominent left lobe. So in this picture, it's a transverse sectioning, as you can see here. It's a transverse sectioning abdominal ultrasound, and you can clearly make out liver cirrhosis with nodular formation, right? Now, apart from that, the other tests are abdominal CT, liver, or bile duct MRI. So this is a picture of a CT scan, and here you can observe marked ascites. Apart from that, we have endoscopy, where we do gastroscopy in patients with established cirrhosis to rule out varices, right? So any patient that we know who has cirrhosis, you have to regularly, in every 1 or 2 years, do a gastroscopy to rule out any esophageal or colorectal or gastric varices, because these are like potential sites for bleeding and further complications. Apart from that, finally we have ERCP or MRCP, which are the MRI of biliary tract and pancreas. So with this, we conclude our lecture on the clinical features as well as the imaging. Let's go over what we've studied so far once again. So we began with a general overview where we saw the clinical presentation could be variable, it could be asymptomatic, incidental finding, and we saw that the clinical features could be a result of liver dysfunction, portal hypertension, and non-specific. So this makes it quite easy to actually remember the clinical features and complications, right? So we saw some non-specific clinical features. We saw hepatomegaly, jaundice, some circulatory changes such as spider telangiectasia and Palmer erythema, and some hormonal changes such as gynecomastia in men. Then we read a little bit about ascites, and then we moved on to things that could be caused due to portal hypertension, which were varices, splenomegaly, and the bruit. So we saw certain unspecific ones like nail changes, hypertrophic osteopathy, Dupuytren's contracture. Apart from that, we also saw certain known ones such as fetal hepaticus and hysteresis. We saw certain advanced ones like hepatic encephalopathy, hemorrhagic tendencies, sensitivity to medications, and hepatorenal syndrome. So in the diagnosis, we saw the gold standard was liver biopsy, and apart from that, during physical examination, these were the signs that we have to look out for. We saw the lab findings, and particularly more importantly, the reduction in platelet count, liver function test, and liver damage test results. Then in imaging, we saw the result of liver ultrasound, abdominal CT, and how it's important to constantly do gastroscopy in patients with established cirrhosis. So with this, we come to the end of the lecture. I hope that it helps you in whatever way possible, and I hope to see you forward in another lecture soon. Thank you so much for watching, and I hope you have a good day.